let your gentleness be evident to all. The Lord is near. Okay, cocaine. Last time we left off with cocaine. Cocaine intoxication results in impaired judgment, pupillary dilation, hallucinations, including tactile. So you have tactile hallucinations. Commonly, they see bugs crawling on them. They feel bugs were crawling on them or under their skin. Okay, that's one. Now, paranoia. You also see paranoia in cocaine intoxication. Then you have angina and sudden cardiac death. Chronic use may lead to perforated nasal septum due to vasoconstriction and resulting ischemic necrosis. In the last video, I had shown you the septum of the nose being destroyed with chronic cocaine use because you snort cocaine. And you can also create a hole in your hard and soft palate. Okay, so yes. And this is due to the vasoconstriction caused by cocaine, and it will end up leading to ischemia and necrosis. So treatment for cocaine intoxication will be benzodiazepines, but benzodiazepines 1, it's safe to give benzos. Now, if you're going to give a beta blocker, you have to give one that is alpha and beta mixed, that has both alpha receptors and beta blockers. Alpha and beta receptors, like labetalol, for the hypertension and tachycardia. So to bring down the BP in somebody that is has overdosed on cocaine, you want to give a mixed blocker that has alpha 1 and beta receptors. So you want to give something like labetalol. You do not want to give a pure beta blocker. So a pure beta blocker is one that only blocks beta receptors. And pure beta blockers are atenolol and metoprolol. And atenolol and metoprolol only block beta 1. Propranolol blocks beta 1 and beta 2. And propranolol will be non-selective. Okay, so there's a few things we had to know here. So for cocaine intoxication, you want to give a mixed alpha and beta blocker because that drug has both alpha and beta receptors. You do not want to give a pure beta blocker, which can be selective beta blockers or non-selective beta blockers. Selective beta blockers are, which it means that it only blocks beta 1 receptors, like atenolol and metoprolol. These are both selective beta 1 blockers. Non-selective beta blockers would block both beta 1 and beta 2 receptors. And an example of a non-selective beta blocker would be propranolol. And the reason you don't give pure beta blockers in somebody with cocaine overdose is because a pure beta blocker is not given in cocaine overdose because pure beta blockers cause unopposed alpha stimulation. So if you block only beta receptors in a patient with increased catecholamine from the cocaine, the alpha receptors are still active. And this would cause unopposed alpha activity. And this will lead to severe vasoconstriction, increased hypertension, and worsened coronary artery vasospasm. Okay, that's why. It would cause so much alpha activity that it will there's nothing to oppose the alpha, and this will cause the coronary artery vasospasm and can lead to death in somebody that has a cocaine overdose. So you want to give a mixed alpha and beta blocker, or the safest bet would be benzodiazepines to calm them. Now the last stimulant that we're going to talk about is nicotine. Nicotine, when you have too much of it, it will cause restlessness. Now, nicotine withdrawal, you'll see irritability, anxiety, restlessness, decreased concentration, increased appetite and weight changes. So you'll see increased appetite, increased weight. If you noticed, a lot of smokers are skinny, on the skinnier end, right? So smoking suppresses appetite, but when they withdraw from it, their appetite increases. Okay, so treatment for nicotine withdrawal will be a nicotine patch, gum, lozenges, and drugs would be bupropion and varenicline. Okay, so bupropion, how I think of because I get mixed up between bupropion and buspirone. Bupropion, I think of B positive. So nicotine, you want to stop smoking. There is not one good thing that comes out of smoking. So when someone stops smoking, which is what you give for to stop the smoking cessation, you give bupropion. So it's a positive thing that you're doing by stopping smoking. So buspirone does not have P in it, but bupropion has P in it for positive. So that's how I remember that. Now, hallucinogen. We're going to start with LSD. Lysergic acid diethylclamide. Intoxication causes perceptual distortion. It can cause visual and auditory distortions. It can cause depersonalization, anxiety, paranoia, psychosis, and flashbacks. Okay. Non-disturbing flashbacks. Oh, I guess different from PTSD, because PTSD would be like you don't. It's like disturbing to people with PTSD, right? Flashbacks in LSD, I guess they're usually happier, like better. It's not alarming to the patient when somebody has LSD flashbacks. It's more like they're in a high, like a happier time. So that's what this means, I guess. Flashbacks, usually non-disturbing. Okay, marijuana. Marijuana is a hallucinogen. It can cause euphoria, anxiety, paranoid delusions, perception of slow time, impaired judgment, social withdrawal, increased appetite, dry mouth, conjunctival injection. So this is what it is. It's like really red eyes. Redness and inflammation of the conjunctiva. So, yep. And marijuana can cause hallucinations. The pharmaceutical form is dronabinol, and dronabinol is used in chemotherapy, so they don't throw up. So dronabinol is used as an antiemetic in chemotherapy patients. Um, and it is also an appetite stimulant in AIDS patients. So dronabinol stops patients on chemotherapy from throwing up, and dronabinol increases appetite in AIDS patients. Marijuana withdrawal causes irritability, anxiety, depression, insomnia, and restlessness, and decreased appetite. MDMA is known as ecstasy. It is a hallucinogenic stimulant. It causes euphoria, hallucinations, disinhibition, hyperactivity, increased thirst, bruxism. Bruxism is when someone squeezes or rubs their teeth together, often during sleep, and can cause jaw pain, headaches, and tooth damage. So it's clenching their teeth together. Okay, then you also see distorted sensory and time perception in MDMA intoxication. Life-threatening effects include hypertension, tachycardia, hyperthermia, hyponatremia, which is when there's very less sodium in the blood, and it can also cause serotonin syndrome. Now, withdrawal can cause depression, fatigue, changes in appetite, difficulty concentrating, and anxiety. Phenylcyclidine intoxication causes violence, impulsivity, psychomotor agitation, nystagmus, tachycardia, hypertension, analgesia, psychosis, delirium, seizures. Trauma is the most common complication. Okay. This is when somebody's like extremely violent, and people are not able to um, restrain them. Um, Usually, it'll be on PCP, and they also have nystagmus. Those are the identifying like criteria for PCP over intoxication. Alcohol use disorder. This is a physiologic tolerance and dependence on alcohol with symptoms of withdrawal when intake is interrupted. Complications: vitamin B1 deficiency, alcoholic cirrhosis, hepatitis, pancreatitis, peripheral neuropathy, testicular atrophy. The treatment is naltrexone, reduces cravings, acamprosate, and disulfiram, which is used to condition the patient to abstain from alcohol use. There are support groups such as Alcoholics Anonymous, which is helpful in sustaining abstinence and supporting patient and family. Okay, so Wernicke-Korsakoff syndrome um, results from vitamin B1 deficiency. Symptoms can be precipitated by administering dextrose before vitamin B1. Triad of confusion is ophthalmoplegia, ataxia, may progress to irreversible memory loss, confabulation, personality change. Treatment is to give IV vitamin B1 before the dextrose. Okay. So here, Wernicke-Korsakoff syndrome, you get it. You've seen it in alcoholics. Um, this um, this is from vitamin B1 deficiency. The way you get this is by one, first being alcoholic. Number two, the symptoms come from giving the dextrose before vitamin B1. So you do not give dextrose first. You have to give B1 before the dextrose. Okay? Alright, so triad of confusion, ophthalmoplegia, weakness is a weakness or paralysis in the eye muscles. Okay, and then ataxia. Ataxia is impaired balance. Okay, so you see this in Wernicke's encephalopathy. Ophthalmoplegia, so paralysis of the eyes, and they can't walk in a straight line. And so that's somebody with Wernicke's encephalopathy. Now, Wernicke's encephalopathy can progress into Wernicke-Korsakoff syndrome, which is irreversible memory loss, confabulation, which is when you make up things because you can't remember what actually happened, so you make up things. That's confabulation. Personality change. And this is Wernicke's-Korsakoff syndrome. So Wernicke's encephalopathy progresses into Korsakoff syndrome, which is irreversible memory loss, confabulation, personality change. And the treatment for Wernicke-Korsakoff syndrome is to give the B1 first, then the glucose. Sorry, dextrose. Okay. Next, we have this. So behavioral therapy teaches patients how to identify and change maladaptive behaviors or reactions to stimuli. Examples include systematic desensitization for treatment of phobia. So it teaches how to change behaviors or their reaction or patient's reactions to external stimuli. Examples include systematic desensitization for treatment of phobia. This example would be taking a patient who is terrified of pit bulls to pet pit bull puppies, right? So this is systematic desensitization. Cognitive behavioral therapy teaches patients to recognize distortions in their thought processes, develop constructive coping skills, and decrease maladaptive coping behaviors. And there's a greater emotional control and tolerance of distress. Okay. Examples include recognizing triggers for alcohol consumption. So CBT teaches patients to recognize distortions in their thought process, develop constructive coping skills, and decrease maladaptive coping behaviors. Develop constructive coping skills and decrease maladaptive coping behaviors, and there's a greater emotional control and tolerance of distress. Examples include recognizing triggers for alcohol consumption. So this is a therapy that teaches patients to recognize patterns or distortions in their thought. And how it teaches them how to cope with things and decrease the bad type of coping behaviors. So examples include recognizing triggers for alcohol consumption, that's for CBT. Dialectical behavioral therapy is designed for use in borderline personality disorder, but can be used in other psychiatric conditions as well as depression, Interpersonal therapy focused on improving interpersonal relationships and communication skills. Supportive therapy. This utilizes empathy to help individuals during a time of hardship to maintain optimism or hope. Prefer medications for said psychiatric conditions. For ADHD, you want to give stimulants such as methylphenidate and amphetamines. For alcohol withdrawal, you want to give benzodiazepines such as chlorodiazepoxide, or lorazepam or diazepam. In bipolar disorder, you want to give lithium, valproic acid, carbamazepine, lamotrigine, and atypical antipsychotics. You want to avoid SSRIs in bipolar disorder as it can trigger mania. Next, bulimia nervosa, you want to give SSRIs. In depression, you also want to give serotonin. You want to give selective serotonin reuptake inhibitors. We're just going to call them SSRIs. Generalized anxiety disorder, you also want to give SSRIs, and you can also give SNRIs, which is selective norepinephrine reuptake inhibitors. In obsessive compulsive disorder, you can give SSRIs, venlafaxine, and clomipramine. In panic disorder, you give SSRIs, venlafaxine, and benzodiazepines. In PTSD, you give SSRIs and venlafaxine. Schizophrenia, you give atypical antipsychotics. Social anxiety disorder, you give SSRIs, you give venlafaxine, and if the anxiety is only in cases of public speaking, you give beta blockers or benzodiazepines. Otherwise, if it's another like social anxiety problem, let's wait. Let's see. So, if it's like if someone is avoiding social interactions, like in parties, public speaking, or even eating in front of others because they're afraid of being criticized by others, that is social anxiety disorder, right? And for that, you give SSRIs or venlafaxine. But if this anxiety is only when they have to say a speech, that would be performance only type. And you give beta blockers in that situation, or benzodiazepines in that situation. Next, we have Tourette syndrome. In Tourette syndrome, you give antipsychotics like fluphenazine, risperidone, and you can also give tetrabenazine. So tetrabenazine belongs to the vesicular monoamine transporter 2, VMAT2 inhibitor drug class. It works by reducing dopamine, serotonin, and norepinephrine in the brain. Okay. So yeah, it works to decrease the dopamine, serotonin, and norepinephrine in the brain, just like antipsychotics. Okay, next we have CNS stimulants, which are methylphenidate, dextroamphetamine, so that's methylphenidate, dextroamphetamine, methamphetamine, and lisdexamphetamine. Uh, these all work by increasing the catecholamines in the synaptic cleft, especially norepinephrine and dopamine. Remember that norepinephrine and dopamine, they increase the catecholamines, right? What are catecholamines? Catecholamines are a group of neurotransmitters that include dopamine, norepinephrine, epinephrine, right? Okay, so norepinephrine and dopamine are catecholamines. Okay. All right. So they all okay. So methylphenidate increases the norepinephrine and dopamine in the synaptic cleft. Okay. Just so you know, synaptic cleft. Is right here. Okay, so this is the axon terminal, and this right down here is the dendritic spine. This area right here is the synaptic cleft. Okay, so norepinephrine and dopamine gets increased here when you give amphetamines. Okay, next. Okay, clinical use for amphetamines is ADHD, narcolepsy, and binge eating disorder. Adverse effects: nervousness, agitation, anxiety, insomnia, anorexia, tachycardia, hypertension, weight loss, and tics, and bruxism, which is when you clench your teeth together. This makes sense, right? Hypertension. Because when you have too much increase in catecholamines, right? When you have increase in the catecholamines in the synaptic cleft, especially norepinephrine, that would cause hypertension because norepinephrine increases alertness and blood pressure, right? Okay, now we're going to move on. To typical antipsychotics. So for typical antipsychotics, these include haloperidol, pimazide, trifluperazine, fluphenazine, thioridazine, and chlorpromazine. The mechanism of action of these antipsychotics is to block dopamine, right? Is to block the dopamine. So antipsychotics, um, they block dopamine, specifically the D2 receptor, and this would increase CAMP. So how this works is D2 receptors are GI coupled, right? Normally. So D2 receptors in our body are GI coupled, meaning the D2 receptors inhibit adenyl cyclase, which lowers the CAMP level. So by blocking D2 receptors, the antipsychotics increase CAMP. I'll repeat that. The mechanism of action for antipsychotics is to decrease the dopamine in your brain, and so you're going to decrease the dopamine in your brain, and the way they do this is the antipsychotics block dopamine D2 receptor, and this ends up increasing CAMP. Okay, so here's how that works. D2 receptors are GI coupled, meaning D2 receptors inhibit adenyl cyclase, which decreases CAMP level, and that's normal, right? D2 receptors are GI coupled, meaning D2 receptors inhibit something known as adenyl cyclase, ADENYLYL, adenyl cyclase, which would normally decrease the CAMP level. But since you're blocking the D2 receptor, you're going to increase the CAMP level in the body. Okay? Next, typical antipsychotics. It's given for schizophrenia to reduce the positive symptoms. What are the positive symptoms? Hallucinations, right? Hallucinations, delusions, anything that's added on. Like, remember how we talked about positive symptoms or anything that's added on to a person, and negative symptoms are it's what's taken away, like flat affect, depressed mood, poverty of speech. Those would be negative symptoms. Positive symptoms are hallucinations and delusions. So typical antipsychotics treat the positive symptoms. You also give this for psychosis, like you give antipsychotics for psychosis, for bipolar disorder, for delirium, Tourette syndrome, Huntington's disease, OCD. Use antipsychotics with caution in somebody with dementia. Potency. High potency antipsychotics would be haloperidol, trifluoperazine, and then flufenazine. There are more neurologic side effects in high potency antipsychotics. They can cause EPS symptoms, which are extrapyramidal symptoms. Extrapyramidal symptoms are these. So EPS would be these would all be EPS symptoms if it was more clear. Let's see. Okay, so these are all EPS symptoms. And after years, you get something known as TD, tardive dyskinesia. This is tardive dyskinesia. These would all be types of EPS symptoms. Okay, so remember in acute dystonia we talked about the eyes being paralyzed. Looking up oculogyric crisis, tongue protrusion, torticollosis, acute dystonia, right? It takes hours to days and days to weeks. You see something in pseudoparkinsonism, tremor, cogwheel rigidity, shuffling gait, and then akathisia is also seen in days to weeks. It's like restlessness. Months to years, you see grimacing, excessive blinking, lip smacking. So, yeah, those are more common in typical antipsychotics, which is first generation antipsychotics, especially with high potency antipsychotics, which is haloperidol, trifluoroperazine, fluphenazine. Okay, next we have low potency antipsychotics, which will be chlorpromazine, thioridazine, and these low potency typical antipsychotics cause more anticholinergic effects and more antihistamine effects, and they cause alpha 1 blockade effects, right? So the anticholinergic effects would be dry mouth, increased heart rate, blurred vision, and decreased sweating. They can't pee or poop. I wrote that so I remember, but just remember the anticholinergic effects would be urinary retention and constipation. Yeah, so you see increased heart rate, dry mouth, decreased sweating, blurred vision, urinary retention, and constipation. In anticholinergic effects, alpha 1 blockade would be hypotension. So adverse effects of typical antipsychotics would be that they're lipid soluble, which if they're lipid soluble, it means antipsychotics are dissolved in the fat, so then they take longer to get cleared from the body. So since they're lipid soluble, antipsychotics get stored in body fat, and they're slow to be removed from the body. Endocrine effects would be dopamine receptor antagonism, which will lead to hyperprolactinemia, which will lead to galactorrhea. You also have oligomenorrhea and gynecomastia. Okay, we're gonna get into that. So the effects of antipsychotics would cause galactorrhea. This is galactorrhea. So this is what galactorrhea looks like, right? And that is both in men and women due to the use of antipsychotics. Oligomenorrhea, women would have very few periods or menstrual cycles, and you would see gynecomastia in men. So We'll get into the physiology in a bit. The metabolic symptoms would be dyslipidemia, weight gain, hyperglycemia. Okay. So, and then anti-muscarinic um, symptoms would be dry mouth and constipation. Antihistamine effects would be sedation. Alpha-1 blockade um, is seen also. This would be adverse effects of the antipsychotics, and then that would be orthostatic hypotension, um, cardiac. Uh, you would see QT prolongation. Remember we talked about QT prolongation. Yeah, ophthalmologic. Um, Chloropromazine would cause corneal deposits, and thyroidazine would cause retinal deposits. Okay, so corneal deposits. So let's see. See that? That's what that is. So this would be the corneal deposits here. See this, and you can see the deposits in the cornea. Okay. So, and then in thyroidazine, the deposits would be in the retina, and you can see that here. Okay. So this would be a normal retina. Okay. And then in thyroidazine, you would see like dots. I'm trying to find a good picture, but it's probably not. So you see the abnormality, like dots here, right? See dots. Abnormality. Okay, so that's that. Next, you would NMS is an adverse effect of antipsychotics. EPS symptoms, we talked about that. Hours to days, you see acute dystonia, which is muscle spasms, stiffness, oculogeric crisis, which is when your eyes are stuck upwards. Treatment is treatment for acute dystonia is benztropine or diphenhydramine. days to months of somebody being on antipsychotics, they can develop akathisia, which is restlessness. Treatment for akathisia is beta blockers, benztropine, and benzodiazepines. Right? uh, Parkinsonism, which is bradykinesia. Um, the treatment is benztropine and amantadine. Months to years, you can develop. Months to years of being on antipsychotics, you can develop tardive dyskinesia, which is chorea, especially orofacial. Treatment is atypical antipsychotics like clozapine. Valbenazine and deutetrabenazine. So chorea is random muscle movements while you're awake. Chorea is continuous muscle movements when you're awake. Okay, so um, for the tardive dyskinesia, you can get clozapine, valbenazine, and deutetrabenazine. Atypical antipsychotics are aripiprazole, asenapine, clozapine, olanzapine, quetiapine, elaperidone, paliperidone, risperidone, lurasidone, ziprasidone. Mechanism is not completely understood. Most are 5-HT2 and D2 antagonists. Aripiprazole is a D2 partial agonist. Varied effects of alpha and H1 receptors. Clinical use is for schizophrenia, both positive and negative symptoms. So atypical antipsychotics, which are second generation antipsychotics, take care of both positive and negative symptoms. They are also used for bipolar disorder, OCD, anxiety disorders, depression, mania, and Tourette syndrome. You use clozapine for treatment-resistant schizophrenia or schizoaffective disorder, and for suicidality in schizophrenia. Adverse effects: all prolonged QT, fewer EPS, and anticholinergic side effects than typical antipsychotics. And any antipsychotic that ends in apines, like asenapine, clozapine, olanzapine, quetiapine, they would all cause metabolic syndrome, which is weight gain, diabetes, dyslipidemia. Olanzapine and clozapine cause obesity. Clozapine, side effect of clozapine would be 8 granulocytosis. So you monitor the white blood cells frequently. And clozapine can also cause seizures, depending on the dose of clozapine. Risperidone causes hyperprolactinemia, in which you see amenorrhea, galactorrhea, and gynecomastia. So, hyperprolactinemia, the reason they cause amenorrhea is that increased prolactin inhibits GnRH. So GnRH from the hypothalamus is suppressed. So now pituitary gland cannot produce enough LH and FSH, which means that the ovarian follicle cannot develop and the woman can't ovulate. So the egg doesn't release from the ovary into the fallopian tube. So because of this, the ovaries won't make estrogen and progesterone like normal. And estrogen and progesterone is what causes the endometrium to shed. So in somebody with a low LH and low FSH, the ovaries cannot make estrogen and progesterone, and if the ovaries cannot make the estrogen and the progesterone, that means that the endometrium will not shed, and therefore they won't have a period, and they cannot get, like they can't, they won't have a menstrual cycle, so they have amenorrhea. That is how hyperprolactinemia causes amenorrhea, right? So, because of high prolactin, um, GnRH from the hypothalamus is suppressed, and so the pituitary gland cannot make LH and FSH, and because there is no LH and FSH, the ovaries cannot make estrogen and progesterone, and the ovaries cannot make estrogen and progesterone, the endometrium will not shed. Okay. And so increased prolactin suppresses the testosterone also, and this will increase estrogen like activity. So that's why the patient gets gynecomastia. That's why the man will get gynecomastia at increased prolactin. So increased prolactin suppresses testosterone, which would increase estrogen like activity, and this is why a man would get gynecomastia and increased prolactin as a side effect of antipsychotics. Well, this mostly happens in risperidone. Galactorrhea is due to increased prolactin levels. Risperidone blocks dopamine. Blocking dopamine increases prolactin, causing increased milk production in someone taking antipsychotics / risperidone. So that's all about the typical and atypical antipsychotics. So lithium, the mechanism of action is not established. There's a possibility related to inhibition of phosphoinositol cascade. Clinical use for lithium is that it's a mood stabilizer for bipolar disorder, treats acute manic episodes, and prevents relapse. Adverse effects would be tremor, thyroid abnormalities like hypothyroidism, polyuria. Lithium can cause nephrogenic diabetes insipidus. Lithium can cause teratogenesis, um, causes abstain anomaly in newborn if taken by pregnant mother. Narrow therapeutic window requires close monitoring of serum levels. Almost exclusively excreted by the kidney, most is reabsorbed at the PCT by sodium channel. Thiazides, NSAIDs, and other drugs affecting clearance are implicated in lithium toxicity. So what you need to know about lithium is that lithium can cause hypothyroidism. It can cause nephrogenic diabetes insipidus, which is when the kidneys make a lot of dilute urine because the ADH is not working. So no water is being held back. These patients with nephrogenic diabetes insipidus pee everything out. So the urine would be very dilute, and the blood osmolarity would be more concentrated, right? Because you're peeing everything out. That's what polyuria is. You pee out so much. That's why these patients have polyuria, because the ADH is not working. Teratogenesis is defects defects in the baby, right? Lithium can cause that. Lithium causes something known as Epstein anomaly, which is when the tricuspid valve is deformed, so the blood leaks backward from the right ventricle into the right atrium. This is tricuspid regurgitation, and then the right atrium becomes enlarged. Right ventricle function will eventually decline. So that's what Epstein's anomaly is. It's a tricuspid deformity caused by taking lithium when the mother is pregnant. So yeah, when the woman is pregnant. So lithium causes narrow therapeutic window. So you have to. It doesn't take a lot of lithium to cause toxicity. So you have to watch lithium closely. Lithium is excreted by the kidneys. Lithium is reabsorbed at the proximal convoluted tubule by the sodium channels. Thiazide, NSAIDs, and other drugs affecting clearance are implicated in lithium toxicity. Okay. So thiazides and NSAIDs affect um, affect how fast lithium can leave the body. Buspirone. The mechanism of action is that it stimulates 5-HT1A receptors. Clinical use is for generalized anxiety disorder. Buspirone does not cause sedation, addiction, or tolerance. Buspirone begins to take effect after 1 to 2 weeks. Buspirone does not interact with alcohol versus barbiturates and benzodiazepines. So buspirone doesn't interact with alcohol, but barbiturates and benzodiazepines do. It's not a side. These are all like mnemonics. These are mnemonics for to remember the drug. So if you want to remember, you can. This is like where all the drugs act. So we can take a look at this. Yeah, this is the term SSRIs. SSRIs are fluoxetine, fluoxamine, paroxetine, sertraline, escitalopram, and then citalopram. The mechanism of action is that it inhibits 5-HT reuptake. So it inhibits serotonin reuptake, which means that it increases the serotonin in the brain. So the clinical use is for depression, generalized anxiety disorder, panic disorder, OCD, bulimia, binge eating disorder, and social anxiety disorder, also PTSD, and premature ejaculation, premenstrual dysphoric disorder. We went through all of them in the previous lectures. Adverse effects of SSRIs would be it's fewer than tricyclic antidepressants. Another adverse effect would be serotonin syndrome, GI distress, SIADH, and sexual dysfunction. So you would see anorgasmia and a decreased libido. Okay, so SIADH is when there's too much ADH in the body, so the body holds onto a lot of water, and urine becomes very concentrated. So you see hyponatremia and increased urine osmolarity. So if you have too much ADH, you're holding back all that water, and so you're peeing out very little. So the urine would be very concentrated, right? And since you're holding back so much water in the body, you would see hyponatremia. You would see decreased sodium in relation to the amount of blood volume. That's why you have hyponatremia. And in the urine, you would have increased urine osmolarity because you're only peeing out very little urine, so of course there would be more concentration of solids in the urine. Okay, that's why you would see that's why you would see what you see in SIADH, and SIADH is an adverse effect of SSRIs. You also one of the big problems with SSRIs is that loss of libido. So sometimes people go off of it because their um, sexual desires decrease. So that's a problem. So that's an adverse effect of SSRIs. It normally takes 4 to 8 weeks for antidepressants to show effect. So it takes about a month to 6 weeks, is what I've seen in practice. It takes them around 6 weeks to show a decent effect. It doesn't work immediately, is what I'm saying. Next, we have SNRIs, which is serotonin norepinephrine reuptake inhibitors, and the drugs that you see is venlafaxine, desvenlafaxine, duloxetine, levomilnacipran, milnacipran, and the mechanism of action here is that SNRIs inhibit 5-HT and norepinephrine. I can't say these words. Is that SNRIs inhibit serotonin and norepinephrine reuptake. So what that means is that it increases the serotonin and norepinephrine in the brain, and the clinical use would be depression, generalized anxiety disorder, diabetic neuropathy. Venlafaxine is also indicated for social anxiety disorder and panic disorder, PTSD, OCD. Duloxetine and milnacipran are also indicated for fibromyalgia. Adverse effects is that SNRIs increase BP and the stimulant effects and sedation and nausea. BP is increased. Why? Because of increased norepinephrine. Norepinephrine increases BP normally, right? So of course, if we have an increased dose of norepinephrine in your brain, right? Increase amount, not dose, increase amount of norepinephrine in your brain, that is going to increase the BP. That's going to increase the stimulant effects and sedation. Okay, increase the stimulant effects. Sedation and nausea is just another adverse effect that cannot be related to norepinephrine. I'm just telling you so you can make a story up in your head and remember. Alright, so TCAs and the drugs would be amitriptyline, nortriptyline, imipramine, desmipramine, clomipramine, and doxepin, and amoxapine. A mechanism of action is that TCAs inhibit 5-HT and norepinephrine reuptake. So TCAs also inhibit serotonin and norepinephrine reuptake. The clinical use is for major depressive disorder, peripheral neuropathy, chronic neuropathic pain, migraine, prophylaxis, OCD. When OCD, you give clomipramine. Um, you can also give TCAs for nocturnal enuresis. Mm, Imipramine can be given, but imipramine has side effects, so that's limited. Adverse effects of TCAs would be sedation, alpha 1 blocking effects, including postural hypotension, and atropine like side effects, which would be tachycardia, urinary retention, dry mouth. Tertiary TCAs like amitriptyline have more anticholinergic effects than secondary TCAs like nortriptyline. Um, anti TCAs can prolong QT interval. You see convulsions, coma, cardiotoxicity with TCA use, arrhythmia due to sodium channel inhibition. You also see respiratory depression, hyperpyrexia. Confusion and hallucinations are more common in the elderly due to anticholinergic side effects. Um, like with nortriptyline. So, um, confusion and hallucinations are more common in the elderly due to anticholinergic side effects. So, nortriptyline is better tolerated than tertiary TCs. Nortriptyline is a secondary TCA, and that would be better tolerated than a tertiary TCA because secondary TCAs have less anticholinergic effects than the tertiary TCAs. So secondary TCAs would show less urinary retention, less constipation, um, no dry mouth, than a tertiary TCA would. So nortriptyline is preferred in the elderly. Okay. Um, all TCAs cause prolonged QT interval. Um, so something you have to know about TCAs is they are cardiotoxic. Arrhythmia can happen due to sodium channel inhibition, and TCAs can also cause respiratory depression and high fever, which is known as hyperpyrexia. The treatment for TCA overdose would be sodium bicarbonate. So treatment for TCA overdose would be sodium bicarbonate or activated charcoal. Sodium bicarbonate is given to also prevent the arrhythmia that is seen in um, uh, TCA over TCA toxicity. Next, monoamine oxidase inhibitors. The drugs seen here will be transcyclopramine, phenylazine, isocarboxazid, siligeline. Um, Siligeline is a selective MAO-B inhibitor. So there's MAO-A and MAO-B. The mechanism of action for this would be not would for MAO inhibitors is non-selective MAO inhibition leads to increased levels of amine neurotransmitters like norepinephrine, 5-HT, and dopamine. So basically, non-selective MAO inhibition means that Um, um, Neither MAO-A or B is inhibited. So then, if neither MAO-A or MAO-B is inhibited, um, the there will be increase in neurotransmitters. So what you need to know is that MAO breaks down monoamines. Monoamines would be serotonin, norepinephrine, dopamine. MAO MAO breaks down monoamines. So if you inhibit MAO, you block MAO-A and MAO-B, then all inhibitors go up. So MAO naturally breaks down serotonin, norepinephrine, dopamine, right? Now, what we're doing with these drugs is inhibiting MAO, and if you inhibit MAO, there's nothing to break down serotonin, norepinephrine, dopamine, which means that they all increase in the brain. So that is how MAO inhibitors work. By increasing neurotransmitters like norepinephrine 5-HT, which is serotonin, and dopamine in the brain. So if MAO is blocked, all neurotransmitters go up. Clinical use is for atypical depression, anxiety, and Parkinson's disease. In Parkinson's disease, they give sildenafil, which is a MAO-B inhibitor. Okay, so adverse effects would be seen as stimulation, hypertensive crisis, right, because of norepinephrine increase in the brain, and also if you eat MAO inhibitor with foods that contain tyramine. Foods that contain tyramine would be aged cheese, wine, cured meat. So they tell you not to take MAO inhibitor with tyramine-rich foods. Monoamine oxidase inhibitors are contraindicated with SSRIs, TCAs, St. John's wort, meperidine, dextromethorphan, linezolid. This is to avoid precipitating serotonin syndrome. You should wait 2 weeks after stopping MAO inhibitors before starting serotonin drugs or stopping dietary restrictions. What this means is that you have to wait 2 weeks before starting, you have to wait 2 weeks after stopping MAO inhibitors if you're going to start any drug with serotonin in it. And you should wait 2 weeks after stopping MAO inhibitors to eat cheese, wine, and cured meats again, so you don't get the serotonin syndrome. Okay. Next we have last page. Atypical antidepressants. Bupropion inhibits norepinephrine and dopamine reuptake. Also used for smoking cessation. Toxicity, stimulant effects like tachycardia, insomnia, headache can happen. Seizures in patients with bulimia and anorexia nervosa. So bupropion can cause seizures in patients with bulimia and anorexia, right? Because bupropion lowers the seizure threshold. This means seizures are more likely to happen, and bulimia and anorexic patients are already prone to seizure because they have electrolyte imbalance, right? So if you give bupropion, you can worsen that. So that's why bupropion can cause seizures in somebody with bulimia and anorexia. Bupropion does not cause loss of libido. There's a favorable sexual side effect of bupropion. Mirtazapine is an alpha-2 antagonist. This increases the release of norepinephrine and serotonin. It's a potent 5H2 and 5HT receptor antagonist, and H1 antagonist. Toxicity is sedation, which may be desirable in depressed patients with insomnia. Mirtazapine also increases appetite, causes weight gain, which may be desirable in underweight patients. Right? Mirtazapine also causes dry mouth. Trazodone. Trazodone primarily blocks 5H2, alpha 1 adrenergic, and H1 receptors. Also weakly inhibits 5-HT reuptake, so it increases serotonin in the brain. Used primarily for insomnia, as high doses are needed for antidepressant effect. Toxicity is by sedation, nausea. Toxicity is sedation, nausea, priapism, and post-steroid hypotension. Remember priapism as a toxicity, as trazodone toxicity, and think trazodone due to sedative and male-specific side effects. Okay. Toxicity causes sedation, and priapism. You can Google what priapism is, right? So varenicline. This is a nicotinic acetylcholine receptor partial agonist. Remember we talked about acetylcholine having nicotinic and both nicotinic and muscarinic receptors. This one, varenicline, is it works on the nicotinic acetylcholine receptor. Varenicline is used for smoking cessation. Toxicity of varenicline can cause sleep disturbance, depressed mood, suicide ideation. Velazodone inhibits 5-HT reuptake, so it increases the serotonin in the brain. 5-HT1A receptor. It is a 5-HT1A receptor partial agonist. Velazodone is used for major depressive disorder. Toxicity of velazodone causes headache, diarrhea, nausea, and anticholinergic effects. Velazodone may cause serotonin syndrome taken with other serotonin agents. Vortioxetine inhibits serotonin reuptake. It is a 5-HT1A receptor agonist and 5-HT receptor antagonist. Vortioxetine is used for major depressive disorder. Toxicity causes nausea and sexual dysfunction, sleep disturbances, and anticholinergic effects. May cause serotonin syndrome if taken with other serotonic agents. Okay, so that's that. Opioid detoxification and relapse prevention. Intravenous drug users are at high risk for hepatitis, HIV, abscesses, bacteremia, and right-sided endocarditis. Methadone is a long-acting oral opiate used for heroin detoxification or long-term maintenance therapy. Buprenorphine is a sublingual form and is a partial agonist used to prevent relapse. Naloxone is a short-acting opioid antagonist given intramuscularly and by IV or as a nasal spray to treat acute opioid overdose, particularly to reverse respiratory and CNS depression. Naltrexone is a long-acting oral opioid antagonist used for detoxification to prevent relapse. Use naltrexone for a long treks back to sobriety. Okay, so what we understand here is that IV drug users at high risk for hepatitis, HIV, abscesses, and bacteremia, and right-sided endocarditis. Remember right-sided endocarditis for IV drug users. Now methadone. If you heard about methadone clinics and Suboxone clinics, that's what this is. Methadone is a long-acting oral opiate used for heroin detoxification and long-term maintenance therapy. So you give methadone so patients, opioid addicts, do not relapse. It is a therapy given long term. It's a long acting opioid. So it means that it stays in your system a long time, um, so that the patients don't relapse into their old habits. And then they go back to get another dose of methadone, right? So that's methadone. Buprenorphine is also known as Suboxone. It is a sublingual form and is a partial agonist of opioid. One second. Okay, so buprenorphine is a sublingual form. A sublingual form, partial agonist of opioid, used to prevent relapse. So that's also given in clinic. It's known as Suboxone clinics, so the patients don't relapse. Naloxone is a short-acting opioid antagonist given intramuscularly or by IV to treat acute opioid overdose. Naloxone is given to treat acute opioid overdose. Um, it reverses respiratory and CNS depression. Naltrexone is a long-acting oral opioid antagonist used for detoxification to prevent relapse. So naltrexone blocks opioid receptors in the brain there is decreased pleasure sensation to alcohol and opioids. Naltrexone is used to help prevent relapse in people who already detoxed. Naltrexone is a full opioid antagonist, so naltrexone completely blocks opioid receptors. If a patient still has opioids in their system, naltrexone displaces those opioids from the receptors. This sudden removal shocks the body into withdrawal because brain goes from full opioid stimulation to zero instantly. So patient must be opioid free for 7 days before starting naltrexone. So that's why you can't give naltrexone to somebody who is acutely on opioids. Um, Naltrexone is a full opioid antagonist, so naltrexone completely blocks opioid receptors. If the patient still has opioids in their body, naltrexone will come and displace those opioids from the receptors in the body. The sudden removal shocks the body into withdrawal because the brain goes from full opioid stimulation into to zero. So the patient must be opioid free for 7 days before starting naltrexone, so the patient um, won't go into opioid withdrawal. Okay, that's it for psychiatry. We have successfully ended psychiatry session. Okay, see you next chapter.